Okay, here we are. Now we have now the final questions of this discussion. Gave us the floor for this new presentation that is on the inhibitors of PCSK9. We are going to start with this patient. That is a patient that we can receive in the office any day. It's a 56-year-old patient. He has hypertension, dyslipidemia. He is a former smoker, and he had an MI at the beginning of this year. He ended up in PCI to the right coronary. The LDL when he entered the hospital was 202 milligrams, and another thing that was interesting was LPA of 90. This patient was discharged with the treatment that appears here, that is aspirin, beta blockers, ticagrelor, atorvastatin 40. And when the patient was already at home, sometime later we have this consultation, some months later, with this lipid profile. He has LDL of 138, triglycerides of 132, HDL 39. He had normal blood pressure. He was walking very little, and his body mass index was 27. The question that we are going to think about, then we're going to do the poll in some moments, but as regards the medication in this consultation, what is the initial strategy that we should consider as the best option? I would evaluate adherence and do an increase in atorvastatin to 80 milligrams a day. We change the patient to rosuvastatin 20 milligrams a day. We add ezetimibe, or we combine this with an inhibitor of PCSK9. Now, we're going to go back to this in some minutes. Now, the ACC published last year the position in patients with cardiovascular clinical disease. The recommendation, as doctor has already said, a high dose of statins to achieve a reduction at least of 50% of LDL or achieve therapeutic goals. And in the case of patients who have some other risk factors, he already had an infarction, so he has a higher risk. His HDL was low, and his LP was high, as we had said. Now, this patient only reduced 32% of LDL. This is not the reduction that we thought about, and he also didn't achieve the therapeutic goal. So what do we have with this document? Now, we should start by checking adherence, right? To see if patient is taking the medication, and to suggest all hygienic and diet measures. Also to consider all the other risk factors, at least initially, to make sure that he's taking all the statins the right way, to make sure that the dose is the right one, to make the most of the statin treatment, and if we cannot achieve our goal, then in a consensus with the patient on risk and benefit, we can think of a second option, that is to add a different therapy, something that is not a statin, that can be either ezetimibe or inhibitors of PCSK9. Now, the Argentinian Society of Cardiology has already decided on this as well, and says that a patient with clinical cardiovascular disease, we need to give them first the right dose of statins, that is a high dose, we all agree on that, and of course we need to evaluate adherence. This is very important, do never forget it, because the fact that we prescribe the medication does not indicate that he is taking it. We have to make sure that the patient is taking the maximum tolerated dose of statin. Now, if we are already on the maximum tolerated dose and we are not achieving the therapeutic goal in this patient, with this risk, the patient is under 70, we are going to add ezetimibe. Now, if we are with both maximum tolerated dose, we can think of the inhibitors of PCSK9, and now we're going to talk about threshold. What do we consider threshold? We all know our goal. In a high-risk patient, we need to achieve less than 70 milligrams And what does this threshold word mean? What is the value of LDL that we think that calls for intervention? Now I can say, okay, the threshold is the goal, is the same. If he's under 70, he needs some intervention. Or I can say, well, before intervention, even if the goal is 70, I will wait until I have a different value that is probably higher for intervention. What do I have to consider this for this value? Sometimes it's arbitrary, but sometimes it's a discussion on the patient, the cost effectiveness that we were discussing. In the case of PCSK9 inhibitors, the European societies agreed that a patient with cardiovascular disease with a maximum tolerated dose of statin plus or not ezetimibe according to the local guidelines, there are these threshold levels. It could be 140 over 140. Yes, we all know that the goal is less than 70. Or over 100 if there are other risk factors, for example, diabetes, another disease, or heart failure. Now, the same document establishes that we should think of giving these inhibitors when the threshold is over 100 milligrams per deciliter. So, considering these observations, now, yes, I'm going to ask you please to vote for this question. If we think of hypolipemic medication for this patient, what is the best option for him? We are here looking at the results. Now, it looks like, even though some colleagues think of adding different therapies or changing the statin, most clearly think that the first thing to do is to maximize the dose of statins and to make sure that the patient is adhering to the treatment, and I agree with you that this is what guidelines tell us to do. Now we go back to my patient. Remember, we did what you said. We raised the dose to 80 milligrams. We do not think that there is intolerance of any way. He confirms that he is taking the medication just as it was prescribed. We check the hygienic dietetic measurements and see him the following week. We realize that he is already dieting and doing some exercise. He is taking his medication, but we still find an LDL of 128. Now, considering what we have already discussed, we add ezetimibe to his treatment, and we have another control some months later, and LDL was still far away from the goal, and it's over 100. That was our threshold. So what we're going to decide is to give him inhibitors of PCSK9. I'm sorry. Now we are going to go to the second question. Now regarding these PCSK9 inhibitors, there are 4 different options that have to do with their ability to reduce LDL and if there is enough research literature indicating this. Now we know that there is 30 or 40% of diminishment in the LDL, but in the first one we don't think that there is literature. In the second there is. Now the third option is that it's 50 to 60%, but there is no demonstration, no proof of this. Or number 4 is that there is this 50-60% reduction, but there is literature. Now, how do these drugs work? Now, some time ago we thought that there were 2 different actors that had to do with LDL extraction from the blood and to take it to the adipocyte. We thought that there was only LDL and its receptor. But we know that there is a third actor in this film That is this protein that is called PCSK9 that is produced by the liver. And what does it do? It binds to the complex, yes, to this receptor. And what happens when, with this particle, you have endocytosis of the complex? Well, the whole complex is destroyed. LDL is destroyed, but also the receptor is destroyed. Therefore, we do not have that receptor still in use. What happens when, with some pharmacological intervention, we can block this protein, PCSK9? What happens? Well, we are going to have the endocytosis of the complex LDL plus receptor without that protein, and in that context what we get is that only LDL is destroyed, but the receptor is recycled, goes back, and with one receptor we can break different LDL particles. This is how this drug works. What do we know about whether they are good for us? Phase 2, phase 3 studies. These 3 studies with these 3 different drugs, alirocumab, velokumab, and bosicosumab, have analyzed these different drugs with the different patients. Familial dyslipidemia, patients who couldn't tolerate statins, different clinical sceneries. Now, this final particle medication, bosicosumab, has been proved that it's not. It has been discontinued because of use. But alirocumab and evolocumab have continued on trial. Just to think of the Odyssey program, we have 5 different studies here to analyze, and both in patients with cardiovascular history or not, the reduction of LDL is near 60%. Said in a different way, if we say that statins reduce a 30 or 40% the level of LDL, these new drugs can do it between 55 and 60%. Another way of seeing it, how many patients can get to the therapeutic goal? Well, if we see it from this point of view, you can see that in comparison to placebo, patients who received these drugs, 72% of them got to their therapeutic goal in comparison to those who didn't receive it. What do we know about their security? Well, this is a different analysis, again from the Odyssey program. These 3,400 patients, and we have this different proportion of patients with levels of LDL, and we cannot find differences in the problems that we usually look for, muscle problems, cognitive problems, problems in the liver or new diabetic patients, even if we compare them with the patients with lower LDL. Now, we were discussing neurocognitive. Now, this study that is Ebbinghaus, that is actually a sub-study of the Fourier, almost 2,000 patients were evaluated. There were this series of studies that were trying to be found, and in 2.2 years that we followed these patients, there were no differences even in the patients who had LDL below 25. To reduce LDL with these drugs, does it have a reduction in the cardiovascular events? Well, the first study, that is the Fourier study, that we learned about it last year, we evaluated these stable patients with statins and who had an LDL that was different from the goal. We first can see that there is a huge reduction of LDL. We can take it to 32 milligrams per deciliter. The reduction is really important here, and we can associate this with a very significant reduction in the primary endpoint and the reduction of the combined endpoint of cardiovascular death, stroke, or infarction, 20% reduction. Now, the Fourier study shows us that there is no point in which we can see an increased risk by lowering the LDL level. Now, this J effect we can see that we can lower LDL to 30 milligrams or even less than 20 milligrams per deciliter, and we still haven't found a point where the risk stops getting lower. The doctor has shown us the audited outcomes that was presented in the ACC in March this year, and we see that the addition of alirocumab to these patients had an event 1 to 12 months earlier. They were all on statins. Almost 90% were on maximum dose of statins and were not in target. Now the analysis showed that LDL, the achieve of LDL was 50, and the reduction of 50% primary endpoint for the patients who received alirocumab appeared here. An interesting analysis of the subgroups, taking into consideration the limitations of a subgroup analysis, it looks like patients who had an original value of low LDL were the most that had the biggest benefits. If you look at the final results, there is a big reduction of events, but also of risk for any and of death of any cause. This goes in line with a revision that is really recent. This has been published now, and it appeared the basal LDL in studies with statins, most of them. Some of them included ezetimibe, and very few already introduced the inhibitors. It showed that apparently the more basal LDL is reduced, if the original LDL is not very high, it looked like the reduction was not so significant. Yes, it was more significant in patients with high LDL in basal value. Is the risk reduction the one that we were expecting? Is this according to what we knew from statin trials? If you see a graph of this, okay, apparently it looks like both Odyssey and Fourier are distant from the line where all the statin trials appear. It looks like there is a bigger reduction in LDL if we compare the risk reduction with the statin trials. But there is something that we need to consider, that is time. If we think of these studies and we group them in the time that each of these studies were held, we can see that, for example, the PROVE-IT study, that is 2.5 years approximately of follow-up. Now, the follow-up seems, if these trials apparently with 5 years of follow-up, now these new trials with 2.2 and 2.8 years of follow-up, we have this difference that we need to take into consideration. Now we're going to vote as regards the efficacy and literature that supports the reduction of cardiovascular events for these drugs. Now, which of these options do you think that is the one that is most appropriate? Now, the inhibitors of PCSK9 diminish LDL in 30. Okay, here we have the results. Okay. Now we are going. We know that efficacy studies showed that reduction is 50 to 60%, so options A and B should not be considered, right? Now, as we have seen in Fourier and Odyssey, we know that there is literature that talks about this reduction in LDL. So the choice that that most of you made is the right one, the one that I consider. Now, these inhibitors have made a revolution in the treatment of dyslipidemia, but they shouldn't be considered as a substitution for statins. They are not here to take the place of statins. This is something different. The patients with familiar hypercholesterolemia and with cardiovascular disease would be the first two groups if we clinically think of benefits with this drug group. And of course, the most important thing to consider is going to be that we need clear recommendation based on evidence and according to the reality in each of the countries. Thank you so much.